For GIST, we don't use chemotherapy at all. Instead, it's exclusively tablet-based therapies. Now, a tablet therapy might initially suggest something quite simple. You wake up in the morning, maybe after a fresh yawn, you just swallow it, and that's the end of it. But it's certainly not that simple. This is also a crucial point where I firmly believe it's absolutely essential to go to a specialized center, and there aren't very many of those in Germany.
Is there, so to speak, any real hope that GIST might eventually become completely curable?
I am filled with hope that we will be able to achieve a cure and that we can significantly increase the number of patients we are able to heal.
GIST stands for gastrointestinal stromal tumor. Unfortunately, this disease can spread over an extended period without symptoms, and that's why it's not uncommon for someone to be diagnosed when the situation is already inoperable. This means the primary tumor can no longer simply be surgically removed, and it has already metastasized. Today we want to discuss how the therapies actually work in such a case. And dear Professor Bauer, thank you very much for taking the time to join us. You are the head of the Sarcoma Center here at the University Hospital Essen. You are an oncologist, and you once called yourself a sarcoma nerd. So thank you very much for speaking with us about this today. And I think perhaps we should first discuss, what does inoperable or no longer operable GIST actually mean?
Inoperable or not accessible for an operation is something that naturally very much depends on the surgeon's perspective. And if I were a surgeon right now, I'd probably be offended that there's anything at all that can't be operated on. Of course, you can operate on almost anything. The main thing now is, can such a tumor be operated on without causing any subsequent damage, or without having to remove adjacent organs, which would then lead to limitations in one's quality of life? Or in extreme cases, that an operation would be so extensive that it would be life-threatening or fatal. That is, of course, the definition of something that is locally advanced. For GIST, for example, it can be the case that tumors, which in the vast majority of cases occur in the stomach, they grow from the stomach into the retroperitoneal space and also grow into the liver, and that this would mean an operation would be associated with a significantly increased risk. Or also tumors that are very large, which lead to, for example, a lot of the bowel having to be operated on, or a lot of the stomach having to be removed, so that afterwards there is also a change in the function of the bowel. This is what we would refer to as a locally advanced tumor, and it's a situation where when a GIST diagnosis has been made, you generally wouldn't start with a surgical procedure as the very first approach, but instead you would initially receive some form of medical therapy. In this particular case, it's always tablets. We do not use chemotherapy treatments for GIST at all. Instead, we exclusively employ tablet-based therapies that specifically target the precise mechanism driving the progression of the disease.
Now, with many other types of cancer, it's often the case that once a tumor has exceeded a certain size, it's almost automatically assumed that metastases are also present. What is the situation with GIST concerning large tumors and metastases? Do they correlate so directly with each other, or can it sometimes be one way and sometimes another?
So, what we know is that tumor size is one of the independent risk factors, and that even larger tumors inherently carry a higher risk compared to smaller ones. However, there are multiple other risk factors that are directly associated with the spreading, or more specifically, with metastasis. So, for example, we know that the site, the anatomical localization, that is where a GIST develops within the gastrointestinal tract, is also significant for whether metastases form or if the risk is high. The stomach, for example, is the most common site, and the spread of the disease is not that frequent there. This means that a large gastric GIST can certainly have a good chance of being cured by a single operation. In the small intestine, for example, GISTs have a higher risk. And what's more, as we've already discussed in the context of diagnostics, the number of mitotic figures is probably the risk factor that best helps us predict which patients will develop metastasis. This is also a very exciting research field, because in the next few years, we will probably be using a whole range of additional factors that will help us to determine more precisely which patients will still develop disseminated lesions over time or not.
And now I believe It's very important again to state very clearly here, specifically. So, with this film, we are addressing people who either have an inoperable tumor or a metastasis, and also patients who are inoperable and have metastasized.
Yes.
So, we basically have this film suitable for these three cases now.
Yes, exactly, but it can all be independent of each other. There are patients who have already had a tumor operated on and think they are healthy, and a few years later they find metastases. They then only have metastases and no primary tumor anymore. Then there are patients who have a primary tumor and metastases, which is also a special constellation that has its own clinical consequences for what the treatment team may have to do beyond medication therapy. There are patients who have already had a tumor operated on and think they are healthy, and a few years later they find metastases. They then only have metastases and no primary tumor anymore. Then there are patients who have a primary tumor and metastases, which is also a special constellation that has its own clinical consequences for what the treatment team may have to do beyond medication therapy. And then there are patients who only have a locally advanced tumor that exists too.
We have already produced a film concerning the topic of the disease itself. We have just recently collaborated on a film regarding diagnostics. We have already discussed quite a lot about therapy, specifically medication therapy. And I believe it's truly important for patients to understand that even if the diagnosis is as it currently stands, the treatment is highly effective.
The therapy is very effective for the vast majority of patients, and the same principle applies here as we've already heard when we discussed the diagnostics. We absolutely must know precisely what specific type of GIST we are dealing with. Because not every GIST is exactly the same, it is therefore essential that the molecular subtype of the GIST is very clearly and definitively established. And we know we have identified specific patient subtypes for whom we can accurately predict that the therapy will be 100% effective.
What does 100% mean?
That everyone will benefit. Every patient responds to the therapy. I'm saying it like this. Patients who have a KIT mutation in the gene segment 11 or exon 11, they actually always respond to a therapy. It doesn't really happen that they don't respond.
Addressing it also means that it really goes away. Or what does that mean?
This means in such cases that for these patients, the tumor stops growing, and it does so immediately. I would say within a matter of just a few days. And in the vast majority of patients, this also leads to the fact that the majority of tumor cells found in the body truly die off. And this cell death then manifests itself by these metastatic lesions or the tumors themselves becoming smaller. Sometimes when there's a metastasis in the liver, then at the spot where it used to be, it's suddenly just a water-filled or a mucus-filled cyst. Then you still see something, but that's mostly dead tissue. That's what's referred to as a response. But it's good that you ask if that's synonymous with healing. With healing, that would mean that almost 100% of every tumor cell has died and that you could then stop the medication. However, that very, very rarely happens with GIST. But in this particular instance, it signifies for the present that the immediate danger from the disease that has been successfully averted. And sometimes for patients, this drug therapy helps for a very long time, sometimes even a lifetime. Then one might naturally ask, is that like a cure? I believe that if the drugs are well tolerated, then it's almost like a cure. It's almost like a blood pressure pill. You don't usually talk about actually curing blood pressure.
That is absolutely right. Or diabetes?
Yes, that's what I mean.
But afterwards, if you were to perform another imaging procedure, would you still see the tumors or not anymore?
Well, that really depends. There are indeed situations where metastatic lesions can completely disappear. But as I've said before, in the liver, it's most often the case that you frequently observe small holes within the liver tissue, which then simply remain as scars. However, in the peritoneum, with smaller foci or lesions, there are definitely situations where they completely disappear and are no longer detectable, meaning they're no longer visible on a CT scan. If you were to surgically remove these specific areas now, and then you examine those areas under a microscope, you would very often find tiny tumor cells that survive, and then, if you will, also form the seed for resistance.
That's why you always have to keep taking the medication.
Exactly. We have learned that if, for patients with widespread disease, treatment is interrupted or stopped, the disease starts growing again in the vast majority of them.
I believe we should perhaps briefly touch upon once more, where metastases in GIST typically tend to occur.
Exactly. That is also a very important question. This is quite different from what we see with many other malignant diseases. The metastases almost never spread to the lungs. It's an extremely rare occurrence, and the main sites of spread are actually the peritoneum. But this peritoneum is actually just a single layer, which is like a light gliding layer. You can probably imagine the intestines, and most people know this from films like Game of Thrones. If you were to cut open the abdomen with a sword, then the intestines would just spill right out. And of course, that's something we absolutely do not want to do to our patients. But, it's really like a very long bicycle inner tube, all crumpled and coiled up inside your belly. And when it moves, these intestinal loops must be able to move freely. And the peritoneum is actually a sliding layer that ensures the intestines don't stick together, but rather that they can glide smoothly against each other, ensuring nothing gets pinched anywhere and that food can pass through the intestines easily. This means it's not really a fell or skin, but just a thin membrane that surrounds the intestines. And in this actually non-existent space between this membrane that surrounds the intestine and also what lines the abdominal cavity itself, in this space just cells thrive. And this is then seen as nodules lying between the intestinal loops. That's one important site of spread, and the other is the liver. And you can sometimes see that on ultrasound, though it's much harder to see on ultrasound than on CT. Actually, it's best seen in an MRI scan, or MRT, magnetic resonance imaging. That's where these liver metastases are usually seen best.
So, we had already produced a film earlier on the subject of diagnostics, and in that we delved into the topic of mutation analysis. I believe it would also be important to briefly emphasize this again for those affected. Very briefly, mutation analysis, what does it actually offer? What's important to know about it?
Right, there are various, indeed distinct molecular subgroups of GIST, and to determine which of these specific groups a patient belongs to, it is necessary to perform a so-called mutation analysis. This means that a genetic analysis is carried out on the tumor tissue or on a biopsy sample from patients who have received a GIST diagnosis. First, it's important to know if the driver mutation is in the KIT gene, the PDGFR gene, or other rare genes that we don't need to go into detail about right now. That's point one. And the second thing is, the localization of this mutation on the gene also plays a very real role. For example, we know that mutations in the PDGF receptor in gene segment number 12 are one where imatinib works really well. But if it's in gene segment 18 at a particular amino acid, then imatinib simply cannot work. Then you have to take a different medication, and you can well imagine that if you have this analysis and know this, then you avoid patients receiving a medication that doesn't work at all, and they get a medication that does work much sooner. More relevant and more common. In the case of KIT mutations, approximately 1/3 of patients have mutations in gene segment number 9. And we know that for these patients, 2 tablets must be administered instead of just 1 in order to achieve the best possible effect. This therefore also has a very real consequence for patients to know exactly which mutations they possess.
And I believe it's important once again that we now actually begin to discuss the topic of therapy and its various options. When we talk about therapy like this, you said one just has to take 1 pill in the morning. I must say, I find it a bit difficult to put it nicely, but I actually think, comparatively speaking, that sounds quite pleasant.
The images that one, as an affected person, has of cancer therapies are often chemotherapy, hair loss, nausea, vomiting, and the stigmatization that one sees from the outside. And now, a tablet therapy first suggests something that you just swallow down in the morning after getting up, right after a fresh yawn, and that's it. It's not quite as simple as that, naturally. So even though with GIST there's this kind of a miracle that the very first medication that was approved, imatinib, is one of those cancer drugs that causes very few side effects. And for some patients, those who are fortunate, it causes absolutely no noticeable side effects at all. There's almost nothing better than that. It's actually just like a science fiction movie. You take a tablet that causes no side effects, and the cancer goes into remission. That's absolutely wild. Of course, I know patients who would call me crazy if I said imatinib has no side effects. Naturally, there are patients who experience side effects, which can even be quite dramatic. So sometimes there are patients who have such severe side effects that the therapy must be discontinued. Imagine having a therapy that's highly effective, but you can't tolerate it. That's truly bad news because then you'll need an alternative. Luckily, there are alternatives. So, for patients with a KIT mutation, there are now 4 approved medications. And what that means is, if one thing doesn't work out, you have a relevant chance that the next one will. If that one stops working, you have a relevant chance that the next one will work, and so on. There are 4 different opportunities one has to treat this particular disease. However, it's also the case that the tolerability of these therapies, let's just say, tends to lose its niceness, if we want to stick with that specific term. Many patients who might be listening will know this, that some of the therapies used for GIST have side effects that do affect the quality of life. They can cause taste disturbances, they can cause diarrhea, they can also cause skin problems on the hands and feet, and there are hair changes, which also lead to you suddenly looking different from how you normally appear. Things get more complicated, and it also really depends on the specific medication, and then it also depends on the person taking it, both how the body individually reacts to it and how patients individually perceive these side effects. It's clear that someone who does a lot of sports, who has a sore soul, a foot sole, will perceive something like that much more negatively than someone who, let's say, prefers to sit on the sofa, watching TV or just chatting. That means it also depends a lot on what the patients do in their daily lives.
And is it the case that one develops resistances and because of that, you have to switch medications again? Or how does that work?
Exactly. So what happens is that this inhibition of KIT kinase, and that's the mechanism of action through which imatinib functions, it initially works quite effectively for the majority of patients. But at some point, sometimes, or quite frequently in the body, in these scattered lesions or metastases, which had actually shown a good regression, then within these metastases, you suddenly discover a new tumorous growth. If you then remove such a nodule, you will typically find a second mutation in addition to the original one. And this is one that typically results in a scenario where imatinib is no longer able to properly bind, or simply it cannot effectively turn off this activated switch.
Does this happen often, or rather rarely, that such resistances develop?
No, that's very common. And in patients with a disseminated disease that cannot be operated on, this happens in 9 out of 10 cases. Now, you could also say the opposite. At least 1 in 10 patients can take imatinib for life, and it doesn't happen. We don't know exactly why that is. Why it works for so long in some patients, and why it eventually stops working for the majority of patients, we don't understand that. But it is also part of the research projects we are currently undertaking to fully comprehend it.
And what's the typical time for the first medication to start working? Are there any average values for that?
Yes, there are some very good data points, and there are also extensive studies. And then naturally, for those of you who still recall your mathematics lessons, there's something called an average value. And the average value, it then also depends on which specific mutation you have. For each mutation, we can actually indicate how probable it is that such a therapy will eventually cease to be effective. The average value for an exon 11 mutation, for example, is 2 years. However, it's crucial to recognize that the spectrum of individuals who experience this kind of growth is, of course, quite extensive. There are patients in whom we can observe this growth occurring as early as 9 months. And then there are others, as I've mentioned, where absolutely no growth has been detected even after 2 full decades.
Okay. And then we still had a whole range of different options available, so that even if one of them stopped working, we would still have another option to maintain its effectiveness.
Right. So you have to picture this. Back when I took my exams in 1999, none of these things existed yet. The prognosis was so poor that with a diagnosis of GIST and metastases, the average life expectancy was only 12 to 18 months. So patients died very quickly. it was one of the deadliest diseases we had. The situation now is that the vast majority of patients live much longer, many, many years longer, sometimes even for decades. These are, of course, the exceptions, but I am of the opinion that at the moment, the chances are getting better every year, allowing one to live even longer thanks to the many treatment options available. This is especially true when, for example, we are able to incorporate local therapies, perhaps with the goal of completely freeing the tumor from any visible signs of cancerous disease.
That's a very important point, once again, especially when it comes to metastases. Are there any local therapies available?
Yes, that's absolutely correct. It does exist. And the field of metastatic surgery is also something that has seen very significant advancements and improvements over the course of the last several decades. And it's not just the surgical procedures. There are also other methods that can sometimes be combined with the operation. That's why we speak more generally of local therapies or locally ablative therapies. What this means is, for example, in organs like the liver, you can treat scattered lesions, even if they don't exceed a certain size. You can also apply thermal treatment to them. This means you can essentially cook them. You can insert a needle into the metastasis, and then the tip of the needle is heated, and then you can destroy cells as if it were a microwave. It gets heated, and then it breaks down. That is quite effective. It's also possible to perform radiation therapy in the liver region, specifically a stereotactic radiation therapy. What this means is that the radiation therapy beam is highly focused, just like with a magnifying glass. And with this method, GIST can also be very effectively destroyed. So, GIST is a radiotherapy sensitive tumor, at least when it's situated in a location where the surrounding tissue around the GIST is not overly sensitive to radiation either. But you had asked again, how common is that? From my perspective, currently about a fifth, perhaps even a quarter of all patients with disseminated lesions qualify for, during the course of treatment, for example, surgery, for metastases with or without other combined local procedures. And this is also a point where I am of the strong conviction that it is actually essential that you should go to a center that specializes in this particular question, where such procedures are performed on a very frequent basis, and there are not that many such centers available in Germany. This means that this represents one of the decisive situations for those patients who are suffering from a disseminated disease, and this particular aspect should also be clarified within the first 6 months, once a treatment with imatinib has been initiated.
Okay, so if a local metastasis can be surgically treated, but for that one would have to travel to a specialized center, then that's actually still quite acceptable in that sense, because even if you're coming from a considerable distance, you only need to come to the center just once, undergo the operation, and then you won't have to constantly travel back and forth repeatedly.
Exactly. Absolutely right. It would be completely insane if someone were to travel from the Black Forest to Essen now to get a blood test done for the checkups that are required during the therapy. That makes absolutely no sense at all. In the case of an operation, that is something where, from my perspective, it's absolutely worthwhile to even consider making a journey for it, because you can truly benefit from it for a very long time if such an operation is performed. And there are certainly situations that are surgically quite simple, which can also be done in many places. For example, if there's a single metastasis present in the liver, that's something I believe quite a few liver surgeons do. But when we're talking about complex, or rather extensive surgical procedures, these are in some cases extremely challenging operations, and they often extend into the very limits of what is technically possible to achieve, and where, naturally, it is incredibly beneficial if these procedures are carried out by highly skilled surgical professionals who have a lot of experience with it. This is where experience and specialization are absolutely crucial.
And now I really must ask that rather silly question once more. We've just been discussing the Black Forest and the city of Essen. So if I were to come all the way from the Black Forest to this place to undergo an operation, would that actually be covered? Or how exactly would that work then?
I'm not saying that you couldn't have that operated on in the Black Forest. I wouldn't claim that. That's not what I meant to say. I only use that as a geographical example. Let me put it this way. The treatment itself will definitely be covered. It's quite possible that health insurance companies might not cover the travel costs, But fundamentally, in Germany, you still have the freedom to choose your hospital if you want to undergo such a procedure. And precisely, the only thing is that health insurance companies reserve the right to say they won't pay for the travel costs.
I would really like to delve into the topic of quality of life once more. We've just been discussing a relatively advanced disease, as you know. So, what is the quality of life like now, during the course of therapy?
So, the quality of life for patients is very significantly dependent on the specific type of therapy they are receiving. The majority of patients who receive imatinib therapy for a disseminated disease report that they are able to lead a relatively normal life. Many patients go to work or pursue their regular hobbies. There are also people who engage in very intensive sports, even running marathons, while undergoing such therapy. That's possible.
Great, okay.
Not everyone feels up to doing that. Many patients have a slight anemia. That's why competitive sports, especially if you're a competitive person, it can feel quite frustrating if you can't run your personal best time. But for many, it's still wonderful that they can do sports at all. But there are patients who experience side effects that aren't well controlled or that prevent them from doing everything they'd like. Many patients on imatinib also have a slight swelling of the eyelids, especially in the morning when you crawl out of bed. It looks like you don't recognize yourself at first, but that usually disappears again during the day. But I would definitely say that the quality of life is generally quite high. And as I mentioned, the GIST condition itself often doesn't cause a lot of discomfort or even any symptoms at all. So you often don't notice these metastases, at least at the beginning of the illness. Of course, if tumors eventually grow larger, that can naturally change. Regarding the subsequent therapies, which are currently the approved treatments, primarily sunitinib and regorafenib, these are two pharmaceutical agents that can potentially cause quite a number of side effects. I've already described those earlier, so especially skin and mucous membrane side effects are something that can sometimes be very bothersome and can also lead to having to discontinue the therapies. It can cause high blood pressure, which sometimes requires significant treatment, and sometimes, especially in older patients who may already have a pre-existing hypertension condition, cannot be well managed. And with sunitinib, there are also some rare medical conditions, such as, for example, an underactive thyroid gland, which, if not recognized in time, can also be quite dramatic. The be-all and end-all for patients is, for many of these side effects, something can be done. There are active therapies that can alleviate side effects, and sometimes there are also very individual dosing modifications, meaning that one fine-tunes the dosage in such a way that any side effect that occurs is at a level that is acceptable. However, this is something that usually requires a bit of time, which sometimes in clinical everyday practice, also in private clinics, or even in our own setting, is sometimes insufficient. However, this is an area where I firmly believe that we, as a center, have a very important function. Before an effective therapy is discontinued, every possible effort should be made to reduce the side effects to a level where patients can confidently say, okay, I can manage this, and my life is truly worth living.
And I believe there's another important point we haven't even touched upon yet, because we just talked about the dosage. And it's absolutely crucial to actually take these tablets, which are 1 or 2 per day. And then also, do you have to take them daily, or how does it work?
Yes, you have to take them on a daily basis. Although for this particular therapy, which follows imatinib, there are sometimes indeed planned breaks, but those are very precisely prescribed. I would always strongly advise patients against taking these breaks themselves or doing them without prior consultation. So this is something where, as a patient, you eventually gain experience and become your own expert for your illness, allowing you to jointly consider when are breaks justified or not. Breaks that are not agreed upon or that come from a whim, of course, always carry the risk that the disease will simply start growing again. That can sometimes happen very quickly. However, my experience is that adherence, as it's called, meaning the patient's therapy compliance, is high because most patients know that their life is at stake. A disseminated tumor disease is fatal if it is not treated.
But I think that's another thing. Do you have to take it by time, like 8 every day?
No, it's not about being absolutely precise to the minute. It's not even a question of waiting for a full hour, but I would definitely say after 2 to 3 hours, you should really make an effort to stick to the schedule because otherwise your doses might start to overlap or the active substance levels in your system could become too low. This is something one tries to avoid. But I mean, just like in life, sometimes you forget it. Sometimes on a particular day, it's simply forgotten because I don't know, we're at a concert or something like that. That's usually not a problem either, if it's the exception.
And now, one final question. What about the current research? Is there, so to speak, any real hope that it might eventually become completely curable? Or that, beyond the existing 4 medications, perhaps a 5th and a 6th might still be developed?
I am filled with the hope that we will be able to achieve a cure and that we can significantly increase the number of patients whom we are able to heal, even within the remaining time that I hopefully have left throughout my professional career. So this is something where we've recently founded a research consortium, which is called the Road to Healing, Road to the Cure. And the very specific goal of this is for us to try and understand the reasons why it is that not all tumor cells are completely eliminated when we perform a therapeutic treatment, but instead perhaps only 95 or 98% of the cells are affected. And I am absolutely convinced that in the next few years, we will have new therapies, especially combination therapies. Currently, we are only providing single therapies, but with combination therapies, we can significantly increase the number of patients who can be cured. This is also one of the main reasons why it's so incredibly important that patients actively help by participating in these research projects, that patients take part in clinical trials, because this is something that can not only provide a benefit for themselves, but of course also for those who come after them. Patients then help ensure that new medications become available. For those patients, for instance, who are undergoing a surgical procedure while they are receiving imatinib therapy, this is currently an ongoing research project where we are truly hoping that a significant number of patients will be willing to consent to make their tumor tissue available for scientific research purposes, particularly if it is not deemed suitable for standard pathological diagnostic analysis. So we can work precisely on that and understand why, for example, imatinib doesn't work well enough in some tumor cells.
Is there a way to sign up? So for patients who are listening right now who might say, "Oh, I find this interesting. I'd really like to get involved." Is there a specific place where one could register?
Yes, absolutely. They can generally contact me, and then I can assess where each patient stands in their condition to see if a meaningful option exists. But fundamentally, this is something where patients can certainly contribute. And this is something where we will also establish ourselves globally. So we are establishing a global research alliance for the cure, which is in essence a dedicated research alliance focused on finding a cure. Within this framework, the world's leading GIST research institutions will actively coordinate their efforts to intricately interweave and efficiently network all these vital research projects together.
I'm really keeping my fingers crossed for you, and I truly hope that the remarkable and outstanding success, which is already so clearly evident in this therapy, will then continue to progress in this very same way.
All right, thank you very much.
Dear Professor Bauer, thank you so very much. Thank you for your valuable time, and I truly believe that we've gained a really excellent overview for the therapy concerning this particular stage of the disease.
Thank you very much, and thank you for your engagement.